This is the consecutive fifth annual conference of Vidarbha Associations of Physicians of India. On behalf of Vidarbha chapter of API Nagpur, and that too being a host, Yavatmal API chapter is, rather I welcome you all for this conference. In fact, we are late by 1 hour due to yesterday's untoward incidents, and due to this, we will have to cut short the 5 minutes for every faculty rather, or in a discussion. For this delay, I apologize. Yesterday's workshop was very satisfactory. Attendance of delegates was around 68 delegates were there, and faculties from Nagpur, Dr. Barokar, Dr. Fulwani, and Dr. Jain from Bombay. I hope you will enjoy this feast of academic knowledge. Thank you.
Thank you, sir. I would request Dr. B.D. Wag, sir, to say a few words.
Good morning, everybody. As the chairman of the scientific committee, Vapicon, Yavatmal, 2013. It is indeed a great pleasure for me and my members of executive committee to welcome you all for the scientific bonanza, which will be very soon displayed here in the auditorium. We have tried to keep scientific agenda which gives information regarding day-to-day clinic or hospital practice. I may be excused of not accommodating important branches like nephrology, pulmonology, hematology, endocrinology, geriatrics, which need separate conference. Nevertheless, we could accommodate many important topics which will satisfy the need of many practicing physicians. The advent of modern medicine is so fast that it becomes very difficult to keep pace with ever-expanding field of medicine. Conference, CME, lectures by expert and experienced physicians keep us abreast of latest information. In a zest of fast progress and making us more techno-savvy, one question that comes to my mind, are we eroding doctor-patient relation, family relations? We must stop somewhere and look at these aspects too. We have experts like Dr. R.D. Lele, Dr. Subedar, Dr. Khalilullah, Dr. H.B. Rajashekar, and a young physician, Dr. D.R. Patil from Dhulia, who will unmask the riddle of this delicate issue. You as a physician, I know, are compassionate, kind, and peace-loving. So I bank upon these qualities and dare to present this scientific activity. Please bear and excuse me for any lapse. And the first and foremost thing, the delay which is caused is the quality of either white. To set the first ball rolling, I wish to start the first session, which is devoted to various causes of fever. I invite Chairman Dr. P.P. Joshi and Co-Chairman Dr. Harshavardhan Bora to come on the dais and initiate the proceedings. Please.
Good morning, everybody, and I welcome you for this first session of this second day of Vapicon, and a very important session covering all aspects of fever of unknown origin, FEO. We have four topics and four stalwarts from Nagpur who will cover various aspects of FEO. And Dr. Vora, you want to get?
We are always serious when we attend a conference, and our mood is always serious. Our physicians caste is such that they are always serious in their life. But maybe very few people are knowing that we are starting with a fever, and fever apart from the real life, it has got a real story in our life. So it's a very romantic thing to talk about. So fever is very famous, and things that there many poems are being made on fever, and the very famous Hollywood actress Julia Roberts has said that fever is an expression of inner rage. Many people may not be knowing that fever has got a radio station by name Fever 104. Many poems, many songs, many movies, they are being made on fever. And a very famous and a romantic poem I will like to read upon this occasion to make your mood light. Never know how much I love you, never know how much I'll care. When you put your arms around me, I get a fever that's so hard to bear. You give me fever when you kiss me, fever when you hold me tight. Fever in the morning, fever all through night. Everybody got fever, that's something all you know. Fever isn't such a new thing, fever started long ago. And a serious note, physician is not angry at the intemperance of a mad patient, nor does he takes it ill to be railed at by a man in fever. Just so should a wise man treat all mankind as a physician, does his patient and look upon them only as sick and extravagant. With these few words, I present to you the next session, and I invite Dr. S.M. Patil for his first academic lecture. Thank you, sir.
Good morning, everybody. Since it was late, I was waiting in the wings to start my lecture. The topic is fever of unknown origin. This is one of the most important topic for practicing internist or practicing physician. And it's a big topic, and it takes approximately more than 45 minutes to talk about the fever of unknown origin. However, I will have to compress it in a sort of a 15 minutes or less than 15 minutes talk. I will start with the definition. It is a 3 weeks duration with 1 week of hospitalization and failure to reach a diagnosis despite 1 week of inpatient investigation. Nowadays, the new definition says that there is no need to hospitalize the patient for 1 week, and all the investigation can be done on OPD basis. Previously, we used to know only one fever, FEO, or classic FEO, but recently in 1991, Durack and Stitt divided fever of unknown origin into 4 subcategories. One is the classic FEO, which I'm going to talk about. Next is the nosocomial FEO or FEO in the ICCU. Third is the neutropenic FEO or FEO in the immunologically compromised host. And fourth is the FEO in HIV. Classic FEO, where the temperature must be more than 101 on several occasions. Fever should be of more than 3 weeks duration. And there should be failure to reach diagnosis in spite of 3 outpatient visits or 3 days in hospital or 1 week of intelligent and invasive ambulatory investigation. In neutropenic fever, the duration of fever need not be 3 weeks. It should be only 3 days. A patient who is admitted and his fever is not diagnosed within 3 days, then it is neutropenic fever or fever of unknown origin in neutropenic patient. Nosocomial FEO, somebody else is going to talk about it. HIV also, Dr. Bhushan is going to talk about it. Pathogenesis. What causes fever? There are various cytokines which causes fever. There are pyrogens, bacterial endotoxin, and what is the source of these pyrogens? Because this endotoxin pyrogen acts on the macrophages and lymphocytes, then inflammatory cytokines are there. They act on the body hypothalamic set points and you get fever. So what is important is the macrophage and lymphocyte should be stimulated by endogenous pyrogens or bacterial toxins so that they go on producing various cytokines which causes fever. And this production of cytokines is of for prolonged duration. It need not be always bacterial toxin. It can be some sort of abnormality in the lymphocytes and macrophages. That's why you may get fever not only in infection, but in certain disorders of the lymphocyte and macrophages. If it is infection, normally whenever somebody gets fever due to infection or fever due to any cause, that patient receives antibiotics. And most of the infections are controlled with antibiotics because our antibiotics are very good, and powerful and are broad spectrum. But in spite of giving antibiotics, there is a tendency of giving antibiotics to any febrile condition, whether it is viral or not. In spite of giving antibiotics, these patients continue to have fever, which lasts for more than 3 weeks. The reason being, bacteria in these cases lives in a sanctuary where the antibiotics cannot reach, or it cannot be eradicated by host defenses, leading to continuous production of cytokines. Certain neoplastic diseases deriving from macrophages and lymphocytes will also cause release of these cytokines, and you get fever. That's why the fever is more common in leukemias, especially lymphatic leukemias and various lymphomas. What does these cytokines cause? These cytokines cause not only fever, but weight loss, cachexia, elevated acute phase reactant, then raised ESR, depressed serum iron, depressed albumin, inflammatory block anemia, and hyperlipidemia. In etiologies, if you get fever of more than 3 weeks duration, 25 to 50% patients will have infection as cause of fever, while 20 to 30% of patients will have neoplastic disorders, and 15 to 30% patients may have collagen vascular disorders, and miscellaneous or undiagnosed cases are 20 to 30% cases. This percentage may differ in country to country in various studies. These are the various studies where there is a difference in the incidence of the various causes of fever. One important thing here is please focus on the yellow part of the bar. That is undiagnosed. The undiagnosed cases of FUO are maximum in Europe than in India. So even in Europe or even in USA, there is certain number of cases who are undiagnosed, and you cannot reach any diagnosis in spite of all the facilities available in these countries. So FUO is really an enigma for a treating physician. Country-wise, there are various studies, as a combination of various studies. In USA, Europe, Japan, and India, infection in USA is 30 to 33%, while India it is 50%. Neoplasm 24 to 30%, while in India it is 21%. And no diagnosis, the last column is more important. In 9 to 12% in USA, there is no diagnosis. 21 to 26% in Europe, there is no diagnosis. 10 to 22% in Japan, there is no diagnosis, while India, 4% of cases, there is no diagnosis. The etiology of various cases of fever of unknown origin, I already discussed about this thing. One important thing, this sort of very important point that I am going to make here, fever lasting for more than 6 months. As I said, in India, 50% of the cases of fever are due to infection. But this is not true for fever of any duration. If the duration of fever, longer the duration of fever, the chances of it being due to infectious cause is less likely. So any fever lasting for more than 6 months are less likely to be due to infectious cause. In a study of 347 patients in National Institute of Health in USA, only 6% had infection as a cause of fever. This is important because in fever of longer duration, infection is less likely cause of fever, and you have to concentrate more on lymphoma, collagen vascular disorders, or other disorders. There are the case studies which I am going to skip. Now, infection. Infection can be bacterial, localized bacterial infection, or systemic bacterial infection, mycobacterial infection, fungal infection, rickettsial infection, mycoplasmal infection, chlamydial and viral infection. There are the various infection causes. In mycobacterial infection, why mycobacterial infection goes undetected? In most of the cases, you can diagnose tuberculosis easily. But in patients who are having fever of unknown origin, there may be tuberculosis, but you are not able to diagnose it because of certain reason. It is intracellular location of organism, protects them from action of antibiotics. It inhibits phagolysosomal fusion, which reduces microbicidal action of the phagocytes. activation of macrophage function by cellular immune process takes weeks to months and in 10% of cases fails, leading to disseminated disease. And coexistent disease like HIV or various other immunocompromised condition helps in dissemination. In tuberculosis, it is usually disseminated tuberculosis. I remember one patient who had fever of 1 month's duration. On examination, he has nothing except his liver was enlarged, and we thought that probably he might be having lymphoma because of more than 1 month's duration fever. We got his liver biopsy done, and liver biopsy showed tuberculoma. So this patient probably had disseminated tuberculosis, or what is called as hematogenous tuberculosis. In another patient had fever of long duration. His X-ray was normal. He came to me after 1 week, and again after 1 week X-ray was done. The next X-ray showed miliary tuberculosis. So it is disseminated disease that goes undetected in tuberculosis. 50% of patients may lack characteristic X-ray abnormalities. There are many patients with X-ray who are having cough, but X-rays are normal. If you do CT scan shows that there is a good cavity. Skin test for tuberculin test is negative in many cases. ASR may be normal, especially in disseminated tuberculosis. And in tuberculosis which is not detected and causes FUO, in majority of cases it may be extrapulmonary tuberculosis, or it may be associated with some sort of immunosuppression. This is again case study. There are certain bacteria which goes undetected. Why these bacteria that go undetected? Because of their intracellular location, like Salmonella typhi. Now in Salmonella typhi, because of their intracellular location, whatever antibiotic you give, this antibiotic may achieve the bactericidal level in the plasma, but not in the cells. And many times patient comes to fever, you do not know the patient is suffering from enteric fever, you give usual dose of antibiotics, and this usual dose of antibiotics will not be able to eradicate Salmonella infection. That's why in such a situation, you have to give very high dose of antibiotics. If you are giving ceftriaxone, 1 gram of ceftriaxone OD will not suffice. You will have to give 2 grams twice a day for 4 or 5 days. Then only Salmonella will get eradicated because of its intracellular location. Similarly, when you give azithromycin for treatment of Salmonella infection, normally we give 500 milligram once a day for 3 days. But in Salmonella infection, you will have to give 1 gram per day for 4 to 5 days because of its intracellular location. And we want to achieve higher concentration or bactericidal concentration in the cells, not in the plasma. And that's why many patients who come with fever and who are having enteric fever, and they do not respond to usual antibiotics because the dose of antibiotic is not sufficient to kill this organism. The other organisms which have intracellular location are paratyphi, brucellosis, Q fever, psittacosis. There are certain bacteria which undergo frequent changes in surface antigen, causing difficulty in their eradication by immune mechanism. They are Bartonella species, Borrelia species, and Treponema pallidum, which we less commonly see in our practice. Localized infection, like cryptic abscess. Abscess is encapsulated, antibiotic doesn't reach the abscess cavity. Because of its encapsulated nature, the bacteria do not come into the circulation, so blood culture is negative. And low pH, high osmolality, and low PO2 in abscess cavity inhibit antimicrobicidal action of the neutrophils. There may be localized pain, tenderness, which is often blunted in the chronic encapsulated stage. That's why many times these abscesses are missed, and patient may continue to have fever. That's why whenever patients with fever comes to you, you have to look for whether patient is having any abscess somewhere. The classical areas where you can have these abscesses are brain abscess, usually in the frontal lobe. Again, because of the blood-brain barrier, whatever antibiotic patient might have received will not be in the sufficient quantity in the CSF. That's why his abscess will not respond to your antibiotic treatment. Liver abscess or abscess anywhere, if it is encapsulated, will go undetected and will cause fever. They are the abscesses. Endocarditis is another thing. Whenever patient comes with fever, patient may not have murmur or may have murmur, but one should think of endocarditis. There are certain features of endocarditis presenting as fever of unknown origin. This patient may have intermittent fever. Fever may not be very high-grade fever or can be high-grade fever also. And patient may have high ESR. There is no tuberculosis. Fever of longer duration, high ESR, urine intermittently shows albuminuria, trace albuminuria or hematuria. Think of Subbacterial endocarditis because it is one of the most important leading cause of FUO because of infection. And all the patients with FUO should be subjected to 2D echocardiography. And many times 2D echocardiography may also, a patient with a cardiologist may miss vegetations, and so the cardiologist, a person who is doing 2D echocardiography must be expert. And even if he is expert, sometimes we'll have to do transesophageal echocardiography to detect vegetations, because it is very difficult to detect vegetations on 2D echocardiography. Many times blood culture may come negative because these patients are already on some antibiotic. Other infections are UTI. If patient with UTI may come with chronic and intermittent infection or intermittent fever. If somebody comes with intermittent fever is more likely to be urinary tract infection, and urine may show pulses, and one should look for what is the cause of this intermittent or continuous chronic UTI. There may be stone, there may be some obstruction in the urinary tract. Osteomyelitis is another cause of fever which is of longer duration and may go undetected. That's why when you examine the patient, try to find out whether there is any tenderness somewhere, anywhere in the body. Chronic viral infection rarely cause fever of a longer duration, except in HIV. HIV, especially primary infection with HIV, may cause fever of longer duration, may go undetected. So if patient comes with fever of longer duration with lymphadenopathy, young patient, one should always keep in mind that he might be having HIV. Hepatitis B and C in some cases may cause fever of longer duration. One patient I remember, she had fever with rash all over the body and fever of 3 or 4 months duration. And there was no other clues except that she had splenomegaly. The only one clue that I got was that this patient was given ampicillin. And after ampicillin, there was severe exacerbation of the rash. This severe exacerbation of the rash after ampicillin is very classical of infectious mononucleosis. And she was diagnosed as a case of infectious mononucleosis, and subsequently, when she was treated properly, she responded to treatment. Fungal infection most commonly is seen in patients who are immunocompromised host. Somebody is going to talk about it. Parasitic infection. Malaria usually doesn't cause fever of prolonged duration, except in those cases where patients are not given treatment, especially in the remote places in Africa where there is no treatment available. These patients may develop chronic malaria, and they continue to have fever for a longer duration, for months together or years together. That sort of situation doesn't arise in India. In India, malaria infection showing chronicity is probably because of some sort of chloroquine resistance. There are various types of chloroquine resistance, what is called as type 1, type 2, type 3. In type 1 chloroquine resistance, you give chloroquine, fever response, parasite disappears, but some parasite still remains, which you can't detect on peripheral smear. So after a week or so, these patients, they again develop fever. And this goes on. This is one cause of chronic fever in malarial infection. Second cause, we do not give primaquine. So we do not eradicate the hypnozoites in the liver. So this patient may develop chronic fever in malaria. So various infection can cause fever. The most common infection that can cause fever is abscess in 28%, mycobacterial infection in 40%, endocarditis in 12%, and rest are the less common cause of fever. Again, I emphasize, as the duration of fever increases, the likelihood of infection as a cause decreases. Any fever more than 6 months duration is less likely to be due to infectious cause. So causes of FUO lasting for more than 6 months. Here the causes are altogether different. In 19%, none identified, no cause was seen. In 13%, miscellaneous causes. I'll discuss what miscellaneous. Infectious fever in 9%. Granulomatous hepatitis in 8%, neoplasm in 7%, Still's disease in 6%, infection in 6%, collagen vascular disease in 4%, familial maritime fever in 3%, and no fever in 27%. Many patients, they do not have fever, but they come to you with fever. The best thing to ask them to record their temperature regularly. In neoplasm, these are the neoplasm. One is the lymphoma, then non-Hodgkin lymphoma, Hodgkin's, leukemia. There are various neoplasm which can cause fever. They directly produce inflammatory cytokines, or in lympho there may be complicating infection that may cause fever. Collagen vascular diseases are usually missed. Still, this is one important disease which can cause fever of longer duration. I had a patient who had fever for 10 years. Ultimately, she was diagnosed as a case of Still disease. And it is very difficult to diagnose Still disease. The only thing that she makes history of intermittent rash or intermittent arthritis and fever. Her ESR is raised. There is no specific test for Still disease. The only thing that may help you is ferritin. You can do the ferritin levels, and you may get high ferritin level in patients with still disease. And it is a diagnosis of exclusion. Polyarteritis nodosa in 15% of cases, SL in 24%. Temporal arteritis usually is seen in elderly person after 75 years or 80 years of age, because most of the collagen muscular disorders are seen in younger patients. Rheumatoid arthritis in middle-aged and old patients, and in very old patients you may get temporal arteritis. There is a defect in the primary cytokine regulation, that's why it is a dysregulation, that's why you get fever in collagen muscular disorders. Miscellaneous disorders are glandulomatous disease, alcohol-related diseases, vascular diseases, drug fever, hereditary conditions, endocrine disorders, factitious fever, habitual hyperthermia. Granulomatous diseases are sarcoidosis, Wegener's granulomatosis. We think that Wegener granulomatosis is rare, but if you look for it, it is not that rare. In last 2 or 3 years, I have got 3 cases of Wegener granulomatosis. Of course, 3 is not a very large number, but before that, in last 30 years, I have got only 1 case. In last 3 or 4 years, I have got 3 cases. So that means that if you are aware of it, you go on getting the diseases which you think otherwise rare. Crohn's disease and granulomatous hepatitis. Diagnosis, history, clinical examination, and investigations. Investigations, I will not talk about investigation. Management. Observation is the most important thing. Avoidance of empirical anti-TB treatment should be followed as far as possible. Empirical therapies are considered only for the patient who is significantly compromised. If patient is very ill, very sick, in that situation only you can give empirical treatment, whether it is antibiotic, anti-TB, or corticosteroids. Some of the time you have to give corticosteroids, because I had a patient with Wegener granulomatosis. There was no proof for Wegener granulomatosis except clinical diagnosis, and he was put on corticosteroid and cytoxan and endoxan. Corticosteroid therapy otherwise is inappropriate. Prognosis, this is another important slide, determined by the cause of the fever and the nature of underlying disease or diseases. The time required to establish diagnosis is less important. Patient in whom FUO remains undiagnosed, this is very important, generally have a favorable prognosis. Patient coming for 1 year duration of fever, 2 years duration of fever, and you are not able to diagnose it, most likely he will not succumb to his illness. Most cases resolve spontaneously, and 5-year mortality rate for undiagnosed FUO was only 3.2%. Thank you.
Thank you very much, sir, for your very interesting and informative talk. We are already running short of time, but we have some time for no questions here. We'll have these questions at the end of the MFO session. So I call the next speaker, Dr. Avinash Pofri, and he's going to speak on, is Dr. Avinash Pofri here? He's going to speak on FU on neutropenic patients. We know Dr. Avinash Pofri is the leading hemato-oncologist in central India, and the first person to have started bone marrow transplantation in central India.
Right. Good morning, everyone. I might appear a bit fast because I have to cover a large ground in a short period, and that too sort of a curtailed period. But at the outset, let me thank the organizers of Wapicon 2013 here at Yavatmal, President Dr. Rathod, Secretary Dr. Agrawal, and all my friends in API here for inviting me to speak on a topic of a complex nature and with a very, very high mortality, that is a fever in a neutropenic patient. We all know that we cannot sustain life without neutrophils for more than few days, and therefore neutrophils are very, very vital, and a person who develops fever in a state of neutropenia is indeed a medical emergency. The management is very active, rigorous, with high power antibiotics, antifungals, and you don't have too much time to linger on to see how it functions, how the patient goes, etc. You have to see the parameters, responding, not responding, go for the subsequent antibiotic, add antifungals, and we'll go through all step by step. I might like to cover within 10 to 15 minutes. And so our objective is to see what factors predispose to such situation in patients of malignancies, particularly hematological malignancies. Solid tumor patients are susceptible to the neutropenic fevers, but as compared to hematological malignancies, no. Hematological malignancies with pathology